Welcome to episode 2 of Expand Podcast, where we are discussing today the topic Beyond Perio-Ortho Limits with my periodontist friend and colleague, Dr. Todd Scheyer. When it comes to understanding the intersection of and the potential for collective intelligence between perio and ortho disciplines, there is nobody better than Todd to talk about it. I hope you enjoyed this enlightening conversation as much as I did. Let's get started. Today's episode will discuss a very cool topic, Beyond Perio-Ortho Limits, and no one is better, no one can talk about this topic with more knowledge than my buddy, my partner in crime, a great periodontist from Houston, Mr. Dr. Todd Scheyer. And before we start talking, I need to mention, since I mentioned the word Houston, in my opinion, one of the most important centers in the world for digital dentistry, smile design, advanced dentistry, where we are hosting in IHDS the Beyond Perio-Ortho Limits course. And Todd, welcome. I'm very happy that you are here with us.
Thank you, Daniel. It's my privilege and honor to always collaborate with you and the DSD family. Obviously, it's been a great journey, right? It started in residency 2, meeting you there and collaborating with the entire team and learning how I could really bring digital dentistry into a perio practice and then share it with my colleagues and referrals and implement it into our teaching and our research. It's just been a great addition to my career in dentistry, really. I mean, it's changed things dramatically over the past 5 years, and it's given me a new level of passion to teach. I feel that we've just touched the tip of the iceberg here. There are so many practitioners, even in advanced countries like the US, where they're just really not using a full digital workflow. It may be an intraoral scan or a CBCT, but to really bring it to the level of treatment planning on a platform like we have, where the very best from each discipline of dentistry can come together to help the patients achieve their best and truest goal. That's next level, right? And that's what we're doing. We're doing it routinely, and it's awesome. I mean, I can go on and on here. I mean, it helps the practitioner, it helps the patient, it helps the profession. So there's just so many benefits to taking on this type of level of care.
Amazing, Todd. And we can see that we are in the same book, in the same page, almost in the same line when we are talking about digital dentistry, the same passion, right? And this really will to make it better. And the topic today, Beyond Perio-Ortho Limits, it's all about how digital can help us understanding that orthodontics alone cannot solve all cases. In fact, the majority of the cases, we need help, right? And working with DSD, doing digital simulations, interdisciplinary plannings, when we are using the face array, TMJ, as a reference, and we start digitally position the ideal, is very fast. We detect that sometimes we need to move teeth much more than we can. And here I'm bringing the first question I have for today, right? What are the limits of orthodontics? How can we understand where we should stop with ortho and start with an adjunct therapy, such as SFOT, MARPE, orthodontics? You have a lot of experience in periodontist, and probably for many years in the blind era of orthodontics, where we didn't have in the past CBCTs and all this technology we have nowadays. How many cases you must have received with fenestrations, recessions, and problems caused by orthodontics, right? So in your opinion, Todd, what are the limits of orthodontics? When an orthodontist should refer the patient to you in advance, and how can you help him?
Yeah, so I mean, I think it comes when you start thinking about what are our limits. Our limits have been learned for decades, right? We've known the traditional way of treating, placing teeth outside the alveolar housing has consequence, right? And we treated those. So typical referral relationship is once you see recession, send it to the periodontist and they'll fix it, right? And that it works, right? I mean, I can't argue with the fact that if you have a root fenestration, subsequent gingival recession, so the bone is first disappears through the orthodontic process of moving teeth outside the alveolar housing. And then it's treated not with bone grafting typically, and historically at least, it was done treated with a soft tissue graft. And we have patients in our practice for 45 years where that worked. So that's not necessarily the problem. The problem is that we can do better, right? And the most powerful tool we have in this digital world is simulations. And the orthodontists understand this, right? That's what your clin checks are. Your clin checks are crown simulations of the occlusion, right? Now, what if we could take that clin check, that simulation, and put it into a facially generated treatment plan where the lips and the face and the alveolar housing and even the jaw positions from a maxillofacial standpoint can all be considered before we ever talk to the patient, right? The dental team can have this discussion, run a simulation, and see what the limits are, right? So we don't have to think about what the limits are by a millimeter. We need to see them. And if we know that with SFOT for arch expansion, we're going to get a few millimeters, right? So if a few millimeters isn't enough, or even if a few millimeters shows that we're going to take a root that's already outside the alveolar housing, already has a root fenestration, and we're going to expand, it's going to get worse. So because we know that, it's pretty simple. The team can now look at the opportunities to intervene at all age groups, right, including adults, and determine, is anchorage necessary? Is skeletal expansion necessary? Is it a little bit more than skeletal expansion and maybe a distraction case? Is it SFOT with the distraction? SFOT, are we adding bone, soft tissue, anchorage? And then ultimately, even with a great alveolus and teeth positioned appropriately, because of the airway, do we still need to advance the maxilla and mandible, right? So to have that beautiful circle of treatment planning model that we've developed here, myself and David Alfie and Giancarlo Romero and Danielle, you've participated in this to create this opportunity that digital dentistry gives us to understand the limits of that individual patient, right? Risk assessment to the patient, not to the general population, but to that individual patient. We understand their anatomy. We understand their facial aesthetics. We understand their goals. And then we take all that information and we simply run a simulation. I mean, that's cool. It doesn't get any better than that, right? It doesn't get any better to be able to do that simulation and then make decisions and then have all this technology available to us and experts from all over the world to come together and execute and deliver. That's what I think where we're at today, and it kind of helps us accomplish the limits that we have.
Yeah, you brought three very, very important topics here, right? First, the orthodontics as we used to do and the consequences of not understanding properly the limits, right? Orthodontics alone in the past, we were moving based on average studies and we were expanding, moving, and then recessions, and then I refer the patient to you to deal with the consequences of a treatment that should have considered more than just orthodontics, right? And then the second topic is the new orthodontics and new dentistry, actually, that we can actually make a lot of mistakes. We can simulate in advance. We can test drive options. We can see if this final ideal position will have enough bone. And if we don't have enough bone, we can discuss as a team, right? how to overcome this limitation. And depending on how much we are missing in terms of bone, we can make a good decision here, a proper decision. SFOT is enough. Maybe SFOT and MARPE, or maybe we need to refer the case to David Alfie and bring orthogonatics to the table, right? So to be able to do this, probably you receive less patients after ortho to deal with consequences and more patients before ortho to pave the way for a better orthodontics, right? And the third topic, which digital brings to us, is the possibility of the collective intelligence. So I am here in Madrid, you are in Houston with your team, and we can plan cases together, and we can create protocols, we can brainstorm, and in the end, the one who receives the biggest benefit of all is the patient, right? So
absolutely, yeah.
This is all about how to overcome the ortho limitations, which is, by the way, the bone, right? We can move teeth to where we have bone, and if we don't, we need to understand how to overcome this problem, right? Which brings me to the next topic, right? One of the best tools we have, and you control this tool better than anyone here. We have more doctors who understand about SFOT, and for those who are listening to us, means surgically facilitated orthodontic therapy or treatment. We participate in an amazing book. We're going to leave because this topic is important. It's all about we're going to discuss here. And there is a book by Brian Vence. Look the book there. Amazing, Todd. For those who can watch the video later, okay. Surgically facilitated orthodontic therapy from our colleague George Mandelaris and Brian Vence. We had the chance to write a chapter there talking about this, and talk about more about SFOT, Todd. How can this procedure, this technique that the periodontist can bring to the orthodontics universe can help overcoming this limitation? How much, what it is? Talk more about it, because probably everyone here wants to listen from the best.
Yeah, well, I think first of all, I may have been practicing with facilitation for 20 years, but I can't say a thing without my mentors, right? George Mandelaris, who edited this book, and his chapter, by the way, is over 200 pages with over 1,000 references. I mean, it's just, this book, having looked through it again this weekend, it is an amazing, amazing resource for anybody that wants to learn, and not just for SFOT, for all things ortho, Anchorage, MARPE, Dome, orthodontic surgery. It's got it all. And that to me is the gold standard in references. We could talk about my other mentor, Rick Robley, and his early articles. They're very good overviews. But if you really want the current status of SFOT, this textbook has it all. Now, how has this evolved? Well, dramatically, right? Because in the early 2000s, when I was first doing this, it was for challenging cases that were failing orthodontically. So because we had this in our back pocket, we waited till failure, and then we implemented help to move teeth or grow tissue around teeth we're moving. So the classic cases were segmental. They were localized, stubborn teeth. Oftentimes impacted canines that the orthodontist would usually write off and say they're ankylosed. Well, they weren't ankylosed. They were stuck. They were stuck by the confines of the bony housing or other teeth, and we needed to work around those obstacles. So we introduced Anchorage and SFOT to help us with tough situations. So we wrote the first article in Perio on Anchorage, right? So, I mean, let's not have this discussion without talking about skeletal anchorage. It's what MARPE is today, but we used it in such crazy ways back then that would really blow your mind. I mean, that's my favorite lecture to give, but no one asked me to give it, is using skeletal anchorage for remote application to do things we can't do it otherwise, right? Because anchorage is the true factor here. It provides us skeletal anchorage to move teeth. If we're working off of other teeth, we don't have skeletal anchorage, right? Newton's law says if we pull on a tooth, right, we use a tooth to pull on a tooth, well, guess both teeth are going to move unless we have something to anchor that Anchorage to. So Anchorage and SFOT really brought us into this realm of care in Houston, Texas in 2001 and 2002 with our mentors, Rick Robley, the Wilco brothers, to really think outside the box, right? So I would ask all of you listening to this to understand the history. Understand the history of it. It's not new. Maybe new to you and new to the masses, but it's not new to us. We've been working on this for over 20 years. Now we're refining it and making it customized. So every SFOT surgery I do, my orthodontist and I, John Crocken, was a brilliant SFOT orthodontist. We customize the surgery for that patient. What are we trying to accomplish? How much root torque? How much translation? How much expansion? How much intrusion? Cover all the spatial relationships. By the way, that TAD article talks about the 4 aspects of space in which we could use Anchorage. Part 2 of this paper, which I haven't done yet, but we should be, how do we take the 4 space relationships and marry Anchorage with SFOT in Invisalign, digital dentistry, and go beyond the limits we're at today, right? That's next. But to answer your question, Danielle, is that SFOT is a tool. It's just like the other things we have in our toolbox to execute. What I want to drive apart today is that everybody can't just go do SFOT. They can't come take a course with me or Rick Robley or George Mandelaris and go back and implement it tomorrow, even a trained periodontist, because it's much more in the thinking, the treatment planning than is in the execution, the coracotomies, the type of bone graft, the type of suturing, the type of soft tissue grafting. That's all what a periodontist can do or oral surgeon can do quite well. But the treatment planning is critical. And if I'm teaching SFOT today to a resident, I'm saying you got to get digital first. Digital first allows you then to use that type of simulation, platform treatment planning to bring all those tools to the table to help our patients in an optimal way. If you just know how to do SFOT surgery, you're not helping your patient like we can as a team, right? The beauty of digital smile design for us is not about a bunch of cosmetic dentistry at all. It's about bringing David Alfie, the orthodontic surgeon, myself, the periodontist, John Crocken, the orthodontist, say Giancarlo, or many, many other wonderful dentists I work with, to the table to discuss all the elements of smile design and facially generated aesthetics and the airway, and then making decisions, or at least creating scenarios to bring back to our patient. I mean, how powerful is that, Danielle, to then go back to the patient and say, hey, we've looked at everything. You've gone to see the ENT, the airway folks, the maxillofacial, the perio, the ortho, the prosto, the myofunctional therapist, right? Everybody's seen you. We've all put all that data together. And now look what we have for you. Let's do the emotional mock-up.
This is extremely powerful, right?
Powerful, right? It's taken the emotional mock-up to the next level.
Yeah.
Because now we're not just talking about designing a smile. We're talking about designing someone's well-being, exactly, changing their life, right? Yeah. It's unbelievable, and we couldn't do it without the tools that you and I know so well of, and we can only do what we can do, right? We tell our students, our dentists in our community about this powerful tool, and still the penetration rate is so small. So that's our problem. That's what needs to be discussed, is why can we not penetrate the market?
Daniel Ramos here, just taking a quick break from this podcast interview to tell you about the DSD Aligners Course. I host a live stream course where I teach dentists how to treat all their orthodontic cases with aligners, from simple to complex, with clinically validated and science-based protocols. The course takes place over 6 weeks and has 2 weekly sessions. Whether you are establishing Invisalign or clear aligner provider, an orthodontist, or a general dentist just starting out, this course curriculum covers the common challenges with proven systems. To get an idea of what the course is about, you can access a taster class free of charge on the web page that is linked in the notes of this episode. Be sure to check it out, and I hope to see you at one of these upcoming courses. Now, back to the episode. Bringing this conversation to a very now practical and clinical level for those who are listening to us to understand the SFOT technique, which basically is applying corticotomies with or without bone grafting, right?
And soft tissue too, yeah.
Soft tissue. And, when we have a case, we're planning a case, we're simulating, and then we detect that the patient has a constrict maxilla. We need to expand, open spaces, and then the final position, boom, the roots are out of the bone. Basically, what we're going to do, we're going to create this bone, we're going to place bone there. But for everyone to understand why the combination corticotomies and grafting, soft tissue and hard tissue, the beauty of it.
Well, the why is really in the patient diagnosis, right? So if we got a patient with constricted jaws, where CBCT and clinical exams show that these teeth are already compromised as far as their buccal bone and soft tissue support, they present with existing gingival recession, existing hard tissue fenestrations, then, I mean, if you're going to expand them to any level, we need to address the periodontal component to this. So George says it so well. We need a phenotype diagnosis, right? We need a classification of their phenotype before patients start ortho. So, and in my practice, the orthodontists I work with, they don't necessarily know how to classify phenotypes. So I see most all their patients, adult patients, before they start ortho, right? So to have a team approach to diagnose the patient correctly is going to tell you what we need to do. And we have those tools, even without DSD. We have CBCT and a good clinical exam with a good periodontist to show us that these teeth are a risk. If you're going to do any level of ortho, you're placing these teeth at risk and the patient at risk. So now to the next level, not just talking about deficiencies, whether it's jaw deficiencies anatomically, where we know SFOT is not going to advance the jaws enough to take care of an airway problem, right? Or we know not an airway issue, just a dental arch perspective, and we're just dealing with the dental arches, then we're talking about phenotype and bone and soft tissue deficiencies. Right? So we have to first figure out where this patient lies in the whole treatment planning realm, and then at least my role is to help them determine, is this patient prior to orthodontic tooth movement need any treatment? Do they just need soft tissue grafting? Maybe, right? Do they just need bone grafting to torque teeth? So they're not really expanding. They're maybe even bringing the lower incisors back. Well, that's not necessarily an SFOT case. It's just a phenotype modification case. And then there's, of course, the cases where we're expanding or intruding or extruding, where the coracotomies are going to facilitate the tooth movement in a more passive way by creating this rapid acceleratory phenomena of the bone, that if we insult the bone and then put pressure on teeth, the teeth are going to move more passively until the bone is healed. Well, the bone's not going to completely heal until we start moving teeth. The best time to move these teeth is in the first 3 to 4 months. That's where you want to get the most difficult movements made. So there's a lot of orthodontic preparation for that, of understanding, when to intercede with SFOT. Typically, historically, we want to get the patient in a rectangular wire if we're using wires. Now we started a lot earlier because we're using 90% aligners to do our cases. And that's 90% of aligners for SFOT cases and orthognathic cases, right?
Yeah.
So we've really evolved incredibly through Rick Robley's guidance on making our cases more digital, right? Because the level of control with Invisalign to the day is much more powerful than putting a wire and letting it do its thing over the next 4 to 6 weeks. However, one thing here, and I know this is a little bit of an aside here, but orthodontists that don't have a lot of experience, I would start with wires so you don't lose control. Understand how to do it with wires. Slowly but surely, you're going to learn a ton before you really graduate into aligner therapy with SFOT. What's critical, though, is the orthodontist and the periodontist got to make a team, right? They've got to both understand what each other are doing here. to be able to truly customize the treatment plan and determine whether it's soft tissue only, soft tissue and hard tissue, coracotomies, where are the coracotomies happening? How aggressive are the coracotomies? For intrusion cases, I'm extremely aggressive. It's a totally different surgery than the old run-of-the-mill SFOT for arch alignment. So
Basically,
it gets complicated. It gets very complicated, Danielle, that it's really hard in a podcast to deliver this patient-specific treatment planning that I'm talking about here.
The idea for me to bring the tricky questions for you here today. But listen, as I understood, and I know this because I learned from you, SFOT is a personalized solution for each patient, that the digital and the possibility for us to visualize the final position of ortho and have the opportunity to discuss as a team. We are going to define for each patient the needs for the individual, right? There is no one protocol that you are going to use for everyone, right? In that sense, of course, everyone wants to learn the recipe, right? And here, maybe an interesting topic to discuss is when we talk about the limits of orthodontics and what are the limits of SFOT when you know that, okay, this is not for SFOT, I need more. I need orthognatics, I need MARPE. Probably we don't have a number, right? Up to these, we can do more depending on each patient, phenotype, everything. But for those who are listening, any insight about this?
Yeah, sure. I mean, typically when we're talking about expansion, we're talking about, max of 3 to 5 millimeters. Extraction site, when we have to take out teeth, we can close extraction sites way more predictably with SFOT. So if there is an extraction case, we'll do SFOT segmentally to close extraction sites, which are, upwards of 5, 6, 7 millimeters, depending on the tooth. Intrusion with SFOT and TADS, millimeters still. I mean, 2, 3, 4 millimeters. I've seen more. Again, it depends on the patient's bony phenotype. So the surgeon needs to understand the importance of looking at things like the zygomatic buttress or exostoses, thick coracal plates. All these things are critical in the treatment planning process. But I'd say, one, if you want a cookbook, get that textbook.
Yeah,
the cookbook's in there. But then be careful, right? Because that cookbook is not really considering age specifics. I don't just mean a child or an adult. I mean, there's a big difference in doing skeletal expansion on a 30-year-old female than a 40-year-old male, right? So thinking about success rates and in all these things we do, those textbooks haven't been written yet, right? So I'll take mini screw assisted rapid palatal expansion. One of the greatest tools I have in my hands right now to expand the maxilla with a relatively minimally invasive surgery. This is a game changer for orthodontics, an absolute game changer, right?
Yeah.
However, there's no data. I mean, there's some data. The data that Audrey Yoon and I, Mariana Evans, myself, Richard Ting, there are people getting enough cases now where we have some data, but it's not the data that the orthodontic community wants. It's not enough. So I think this is very important too. When we're looking at the limits and what we can accomplish with all these tools, we have to be super careful. We have to provide excellent informed consent to our patients and our referrals. For me, for instance, if I'm working with a new orthodontist, I've got to really meet with them and show them what we've done and help them understand the limitations we have here. And at the end of the day, because this patient's unique, all the work we've done may not be helpful for that individual patient. So I think as we evolve in dentistry, it has to become more and more about customized, individualized risk assessment, right? And that's not just about what we're talking about here. That's about their systemic illnesses, right? The whole patient, their airway, everything they're bringing to the table. And individualize that. Use a team of providers that understand they bring their best strengths to the table. Medical colleagues, all the dental colleagues, bring them all to the table and customize the treatment plan and tell them that we have limitations and we may not be able to always end up with the best results. However, if we are trying to be more conservative, meaning we're going to take a patient, we're going to say, okay, instead of orthodontic surgery, we're going to try to expand the maxilla and do SFOT to coordinate arches, right? More conservative. Those patients all are told they need to go see the orthodontic surgeon, right? So even though we're willing to try to do their case without orthodontic surgery, they understand that if we can't fully execute our plan and they want to get to where they want to get to, then they're going to need to have orthodontic surgery. And that's a wonderful discussion to have with our patients before we get started, right? So we can have them fully educated, understanding our limitations. And even if we're bold to say we can do it without more advanced procedures, we're smart enough to say, go get the consult, right? So you've already heard about something that you don't want to do unless you have to. And that just makes the whole dental team more comfortable having these discussions. And basically it's liberating, right? For the dental team, it's liberating to know that we have all these tools, but there are limitations, and that's okay. So if we meet an impediment, we've got David Alfie to help me out, right? And that's just, it's an awesome thing to have. And it makes much more sense when we use a digital platform to show it, right? If we have a digital platform to show each other and the patient and the patient's loved ones, everybody gets to make it a decision with the ultimate form of informed consent, which is a visual simulation of where we're going.
Yeah. You mentioned something that for us orthodontists is kind of polemic, right? And I would like to dig a little bit deeper. It's the acceleratory phenomenon, okay? For years, I lecture about acceleration, micro-osteoperforations with you, about choricotomies and SFOT. But when I am talking to a group of orthodontists and we start talking about acceleration, always a rain of questions. And I don't know exactly the mistake here, maybe. Is the concept, right? Because when Orthodontics, they presented their studies, their cases, and this technique came before them, right? You know very well. And they fine-tuned and they created a protocol. I believe what they mentioned in the beginning when they first published it, more than to accelerate, it was to make it possible to, right? So the SFOT technique, I don't want everyone to have the same mistake and think, okay, this is another acceleration technique alone. Because in my opinion, much more important that accelerate tooth movement that is going to happen, and we can explain a little bit, but the most important thing is to allow us to achieve the final position we want, or to reduce the chances for issues, right? So, acceleration and periodontal improvement, acceleration and improvement of the predictability. In your opinion, in this combination, what is the biggest reason why we're doing SFOT?
Yeah, so I mean, you're right. When this got brought to, at least in the U.S., when this got brought to the table, it was all about speed, cutting the treatment time in half. And that was a mistake, right? And if you talk to Rick Robley, for us, it's never been about that. It's been about creating the optimal dental alveolar situation to move teeth. Now, the side effect is it does happen faster, right? We can accomplish those most challenging movements, intrusion, extrusion, translation in a significant way. We can accomplish those faster. in that window of opportunity post-surgery. But if the orthodontist doesn't know how to implement it then during that window, then it's not any faster, really. The biggest benefit is the phenotype modification. So, I mean, I'd ask all those orthodontists and periodontists that are thinking about this, you got to learn about phenotype modification. You got to read the systematic reviews and consensus, best evidence consensus publications that are out there online, right? And in the textbook that I mentioned earlier, that has all those references. So you got to do your homework, right? Don't just think you're going to snap your fingers and become the person in your community that's going to have these tools to execute with great predictability. You got to do some training. You got to do some learning, right? And understand what we're talking about here. Because if you don't understand phenotype modification for hard tissue, soft tissue, what's a realistic possibility of you moving the tooth in that position? One, if you never used SFOT, you already have a preconceived notion of how much you can move that tooth. Well, that's got to change. You've got to change your thought process on your ability to move a tooth or a group of teeth, because you can do it much differently with SFOT and other tools, Anchorage, the right orthodontic treatment plan using aligner therapy, the right wire at the right time. There's a lot of things going into it. And if you don't understand it, you don't have mentorship and someone to help you, then you're going to fail. And most likely what I hear all the time is, I tried it 3 or 4 times and it didn't work.
It's not a magical
Show me those
tool, right?
cases.
It's not a magical tool.
It's not magic.
We cannot expect to substitute diagnose, planning, interdisciplinary thinking just by using this tool that we are going to solve all these matters and the case is going to finish beautifully, right?
Right. Absolutely.
The basics in the end still is the most important parts. Planning well and using the proper tools, we have higher chances to finish well. And this tool is still talking about acceleration, because this is a topic that I really liked. Every time we create a surgical trauma in the bone, right, we will generate an inflammatory response. This is basics, right? And when we have the inflammatory response caused by orthodontics, combining both, it's like we are putting a glass of gasoline in this fire and increasing this inflammatory fire, right? As a clinical experience, my clinical experience with aligners, I've been practicing aligners for 15 years, and having all the data from Wilcox and the biological window of opportunity that our papers are mentioning 3 to 4 months. What I detected, and I would like to hear your opinion, is that with aligners, the fact that we are changing the aligners in sometimes 3 days, 4 days, 5 days, we are activating the orthodontics part and increasing and maintaining this inflammatory response higher for longer periods. I have cases that I could change aligners in 3 days for more than these 3 to 4 months.
Yes.
So I believe that by activating orthodontics more often, we can keep this inflammatory response, this acceleration phenomenon for a little bit more time than 3 to 4 months. Do you have any experience with John Karotkin about this?
Yes. Yeah. Same thing. Yeah. Because we're making those changes on a 3-day basis, we can prolong it longer, but still we're seeing it burn out by 4 months. It's not often we're getting 6 to 12 months.
Okay.
So if we really need it, we have to go back and do some minimally invasive coracotomies, more like what you've talked about, this, flapless approach to stimulating the bone only. At that point, if we've already grown good hard and soft tissue, you can do a flapless approach. There's a great paper out by Taka Miyamoto on minimally invasive SFOT. I don't like doing minimally invasive SFOT as the first surgery unless you can show me that it's an ideal circumstance, because if you have thin bone and thin soft tissue, you need to graft it. If you have thick bone, fori, exostoses, you need to get rid of them. So I just don't see a good indication for flapless SFOT.
Okay.
Doing secondary coracotomies after SFOT, tons of times, sometimes just segmentally, right? We got one stubborn area. We can't close one extraction site. We can't intrude one tooth. We can't extrude one tooth. Then we go back and we do a minimally invasive approach to give it a little bit more wrap effect to take care of that area. But generally speaking, our cases are just so, I mean, John just does such a good job of treatment planning, right? I mean, the orthodontist has to understand the treatment planning process. They have to be running the, well, I mean, unless they work with you. If you're just sending them off to Costa Rica and you're letting a tech in Costa Rica design an SFOT case, you know, quite honestly, good luck, right? Because the person doing the orthodontic treatment plan, the ClinCheck simulation, has to understand what we're doing. And how many people, Danielle, do you think really understand what we're doing?
Well, we are raising the flag of SFOT here so more people can be aware of it, because as you know, we don't have much doctors using it, right?
Well, no, but what I'm saying is, if doctors are going to use it and they're not participating in the aligner treatment planning and they're letting a tech do it, SFOT is not probably going to work.
This is, but not only for SFOT case, Todd, for aligners case, the orthodontist should be on board and control the planning. Right?
Yeah. Well, I mean, I know, and I would say, I mean, I'm not trying to, you know, be confrontational here, but you know, maybe some orthodontists are involved, but how about the masses of general practitioners that are using aligner therapy and they're not doing the treatment planning?
My suggestion to them is they need to find a good TPS, right, treatment planning service, so they can have an orthodontist in the end helping them, okay? Because otherwise, they are going to struggle a little bit. They need to learn. They need to follow the same path of an orthodontist to understand biology, to understand tooth movement, to understand biomechanics. Otherwise, again, there is no magic. And this is very important. So this is a very trendy topic, the TPS, right? To have more people helping you with your cases. DSD Planning Center is like a TPS for interdisciplinary cases. So you have the chance to work for your cases with a lot of specialists with experience. So this can help the general dentist to provide good plannings for aligner cases, right? And
I think that was really my hope in your response, was that really, even though everybody doesn't have access to the treatment planning center at DSD, that to me is the pinnacle, right? If you're a dentist out there and you're listening to this because you're DSD interested, or maybe you're already DSD aware, you've taken courses and content, now you're at a level to expand your practice outside of doing just small smile design, that this to me is what we need. We need to have experts at the table doing the treatment planning process, unless all these things we have, SFOT included, can be misused and can be quite dangerous.
Yes, and this is not fair to the patient, right? If there is this possibility, digital is facilitating this communication. You already saw the patient's eyes when you start presenting all the simulations, the mock-up, and explain that there is not me here alone. This is this group of dentist specialists who evaluated your case, how grateful they are, and how increase their trust in the treatment, how more collaborative they become. So for me, it's impossible to give a step back and become again the old school orthodontist locked in my clinic alone, right? As I was used to be in the beginning. It's impossible. And for those who are trying the collective intelligence, interdisciplinary thinking, digital planning, it's like giving a step back, right? And there is no way of doing anymore, and you know this very well. Well,
you can't go back, right?
No.
Yeah, when you have this type of access to information and that powerful word that Christian brought to us of collective intelligence from a dental perspective, right? We've known about collective intelligence in other industries, but to think about this specifically for the comprehensive dental care, it's just, I mean, I could never go back to the old way. That's the power of all this, is to really not just use the technology and the evolving technology that happens daily by the second, but it's the people. It's still the people with the core values, the mindset about patient-centric care, using all these tools, but still having the core values to be thinking about the patient first. It's awesome. I mean, it's just incredible where we're at today if you fully use it. What I know as well as you is that a lot of busy dentists out there, they want to just find the fast way, right? How can I do things faster to make more money? That's not what this is about. It's not about speed. It's about quality control, risk assessment, doing the best for your patient. And if you have that in mind, then man, this platform is a powerful, powerful thing that's changed. I was doing this almost 20 years before I got onto this level of care. And I'm a different person and a different practitioner today because of it. And that's a powerful statement, but it's true.
Yeah, no, completely. And well, we can stay here talking about these for hours, right? But at one moment we need to get to the conclusions. And I believe the main topic today was SFOT. And of course, our goal wasn't to teach the technique, to teach details, right? This is something more comprehensive. And to do a digital planning, to work in a team, to have a specialist will for sure accelerate the implementation, right? The main reason, as you explained, is to improve periophenotype, facilitate orthodontic treatment, allow us to move to where we need to move, and as a bonus, we may accelerate tooth movement for 3 to 4 months. Doing a quick math while you were explaining, 4 months for aligners changing in 3 days, we are talking here about 40 aligners, so we can solve a lot of cases, and this is amazing, right? But again, shouldn't be our main concern to accelerate. This is a bonus. For those who are listening to us, Todd, and your advice, okay? I like it. I want to start doing this. In your opinion, because I don't want to be suspicious here, I want to hear your opinion about the next steps for this doctor who is listening, and he wants to give this next step to make his dentistry better. Where do you think he needs to go and to learn more about it?
Well, it's different now than it was a few years ago. Today, I would say, first, you got to understand digital workflows, right? I mean, that to me is essential to be able to do this the best way. So if you're looking to do this the best way, then I'd become very familiar with digital workflows. And there's various platforms out there. I'm biased, and I don't even know the access to it today. You can speak to that better. But to me, in my Houston community, the first thing I did after Giancarlo and I went and took residency too, is we changed my study club to a digital study club.
Okay.
So they all took residency 1 online. So all the dentists I work with have become familiarized with DSD, right? Game changer, absolute game changer for my referrals. They don't all use DSD. Now they can't because they haven't gone on to become a master and become a clinic. So they have access through me, right? So me and the leader in the community, I provide them this access, and that's a game changer. So they learn digital workflows. Now, how do they now take on more complex cases? Well, the answer is the same: education, right? If you want to become a full arch dentist, there's tons of education out there. Unfortunately, I think there's too much on implants. I think all these full arch implant things, they're not even thinking about airway. They're not even thinking about saving compromised teeth. And, that's a whole different discussion. But I do beg you, dentists out there, think about your full arch dentistry and where you're putting those implants and where you're putting the prosthesis. And I can guarantee you it's affecting their airway. How do you think those patients lost their teeth?
Yeah, right? Good point.
Let's wake up. Let's wake up, folks. because we're creating a whole different level of problems with all these zygos and pterygoids and implants everywhere. But again, that's a different discussion. So back to this. Where do you go find, once you know the digital workflow, once you know that you want to do interdisciplinary care, you want to involve the specialties, or you're in a community where you are the specialist and you have to manage this all yourself because there's no periodontist, there's no oral surgeon, there's no orthodontist. Still, if you're that dentist, get educated, get help. There's wonderful digital labs, right? There's all our maxillary skeletal expansions. We now go to one laboratory because they're the experts. We use one digital platform. That's DSD. And then we use a team approach every case, right? If you don't have that team, it's okay. You can find resources to help you. But if you live in a relatively urban area, trust me, you can seek out those individuals that love what you're telling them. They want to come together as a group of 8 to 10 practitioners and meet on a monthly basis to learn the digital workflow and then to learn interdisciplinary care. Get that textbook. It's all about interdisciplinary care. It's not about SFOT. That's the label on the textbook. It's about interdisciplinary care. There's tons of resources out through Spear Education and COIS about interdisciplinary care, right? There's so much education about pediatric airway and adult airway. There's a wonderful group in the United States called ASAP, ASAP, right? That's more about advanced pediatric airway, but trust me, I'm on their thread. I'm a member, and they talk about adult stuff all the time, right? So platforms out there that are available to us can help you on this journey that I believe you should take, right? And if you really want to feel like you're there, right? You understand it all, and you want to take a course that's going to change your career, be a game changer level of a course, then you take an advanced residency style program like we do in Houston at the Institute for Houston Dental Synergy. This isn't a marketing thing for me, by the way. I mean, I'm super busy. I'm not selling education. That's not what pays my bills. But I will tell you, I put my heart and soul into the course we run once a year called Beyond Perio-Ortho Limits. Daniel knows that because he's faculty. So next year it's going to be Mariana Evans, David Alfie, myself, Danielle, Giancarlo Romero, and John Crocken. You know, we've gone from Danielle and I doing it to try to build the concept to growing it with international experts like Octavio Sintra and Giordani. Yeah, I mean, amazing people of Carlos Soto came and talked as the GP getting into this. We've had amazing faculty, either online or present, to help us, make this course better. And next year should be the best ever. We just did the course in January. It was sold out. And it's where you bring your team. So whether you're a general practitioner, orthodontist, periodontist, oral surgeon, myofunctional therapist, plastic surgeon, whatever, prosthodontist, you come as a team, even if it's only one or two of you, and you learn the digital workflow. So it'd be great if you're already exposed to it, but you don't have to be. You learn the digital workflow, and then you learn treatment planning. How do you treatment plan these cases? Maxillary skeletal expansion, SFOT, orthognathics, prosthetics, all with a digital workflow. And then how do you marry it? How do you synergize it to bring it all together so that you go back to your community with your team and implement it with success? And you still have mentorship. So we have a WhatsApp group from that course we did in January, and we get people, WhatsApping a case that they have and, sharing files easily and asking questions, right? That's how we all learn. And I ask them every day, what else can we do better? What do we have? What's coming next? Where do we go from here? How can we be better? And it's amazing that, Daniel, we're going to be a lot better at this in 5 years, right?
Yeah.
It just keeps, like, I'm 53 years old, right? I'm hoping I've got at least another 10 years of doing this well. But for me to think as a seasoned practitioner that I'm going to get better next year, and in 5 years, I'm going to be even exponentially better than I am today, man, that keeps us going, right? That keeps us energized and inspired to go out there and keep doing this and helping patients and helping the profession.
I believe everyone listening is more energized after your passion, the way you share this information, Todd. Thank you. Thank you so much for being here, participating in the Expand podcast. It was a pleasure to all of us. I am really excited to be with you again next January in Houston, one of the capitals of digital dentistry in the world, right? With amazing dentists that practicing amazing dentistry. Well, I really invite
but
you.
can I say something, Daniel?
Of course.
Very lucky, right? I mean, if we're so lucky we are, because the reason we're doing it is really because of Christian, right? If you think about your three first podcasts, Katie, David, and myself, all from Houston, Texas. The reason we're here is because of DSD, right? DSD shook us up, right? It made us think outside the box and elevate ourselves. And by elevating ourselves, we elevated those around us, right? We created a community. They bought in, they understand it. They spent the money and the time to learn it. And that's what this all about. So those people, listening this today, go do this. It will change your practice for the better, right? And then it'll change you as a person to become even more passionate about what you're doing. So you have better satisfaction on a daily basis, but you have better satisfaction on what you're doing for your patients, right? I mean, that's my why, is the patient. So, you find your why, and trust me, this journey you go on with digital dentistry, it will just be it'll give you back way much more than you give.
Yeah. Well, if you allow, I will use this final message as the final message for this episode. Our why should be our patients. And this is all about Beyond Perio-Ortho Limits, which was our topic today, with Dr. Todd Scheyer, directly from Houston. Todd, thank you. Thank you so much. And hope to see
you, brother.
To have you all listening the next episode here for Expand Podcast.
Thank you, Danielle. Cheers.
Thank you for listening. If you feel inspired to learn more about any of the tools and treatment modalities that Todd mentioned in this episode, check out the episode notes. In the next episode, I will be talking to Dr. Pedro Costa Monteiro about setting the perfect staging. If you don't want to miss it, remember to subscribe to this podcast on your platform of preference. If you think any of these episodes will be interesting to your colleagues, please share the show link with them so they can listen to all the episodes.